So cardiogenic shock is a decrease in the cardiac output and tissue perfusion that leads to a downward spiral of ischemia and myocardial dysfunction that gets worse, organ failure, and sometimes death. Its most common cause is MI, or myocardial infarction. And that's just an overview. The shock occurs in 5 to 8% of STEMI patients and in 2% of non-STEMI patients. The average onset of shock after STEMI is about 7 hours. And then for renal dysfunction, you might see it in 24 hours. Usually the prognosis is worse for shock due to a left ventricular than for right ventricular infarctions. If the person's heart isn't revascularized very quickly, then the mortality rate really spikes. It can go up to 70%. And then if they revascularize it, you could have like a PCI or a cabbage. The mortality rate will drop back down to usually like 40%. Other causes of cardiogenic shock include papillary muscle rupture that results in mitral regurg, constrictive pericarditis, pericardial tamponade, acute ventricular septal defect, cardiomyopathy, and myocarditis. Risk factors are pre-existing myocardial damage or disease like diabetes, pericarditis, previous MI, of course, and 3-vessel disease. If you've had a STEMI or NSTEMI before, with anterior wall damage, that's also a risk factor. Dysrhythmias, conduction abnormalities, and advanced age is also a risk factor. All right, things that you should assess. For cardiovascular assessment, your cardiac index, you should look for, you might find that it's less than 1.8. Ideal is 2.2. You may have a low blood pressure systolically, less than 90. You may have a MAP that's in the 60s. Your SVO2 also can drop. And then your pulses, your capillary fill, all of that is just a cascade of circulatory issues that happen. So your pulses get weak and ready, capillary fill is delayed over 2 seconds. Heart sounds may be diminished or distant. Literature says you may have a S3 or S4. And then for the EKG, you will have rhythms. You could have rhythms like SVT, VT, or VTAC, bradycardia, sinus bradycardia. You can have AV blocks. You can also have intraventricular conduction delays. With all of this, the EKG can look normal. Person may be dyspneic and have crackles or wheezing. They may have pulmonary edema, so your CVP may be elevated, your pulmonary arterial pressures, your neck veins may be distended with your assessment. Renal wise, your urine output goes down. Normal renal output is 30 cc's per hour. Skin, you have some cold and clammy skin because of vasoconstriction. Maybe mottled extremities, could be upper extremities or lower extremities. Neurologically, the person may be restless, they could be agitated, they could be confused and anxious. And then for GI, they may have nausea and vomiting. A lot of the times we see that in women, you know, who have MIs. They don't have the typical, you know, chest pain kind of scenario. They have more GI symptoms. You also may see decreased bowel sounds because of the decreased perfusion to the gut. What else? Your labs. So you'll find that in your labs, you may have some hypoxemia, metabolic acidosis. You may have a high CO2, actually no, a low CO2 hypocapnia. You may have lactic acidosis. Per literature, it says that you could have a prognosis that's poor if the lactate is over 4. Well, in my experience in the hospital that I work at, I have seen lactate levels as high as 17 and unreadable. And those people are like really, really sick. And usually they have multi organ failure. Your BUN and creatinine might trend upwards, and also the potassium. All right, how do we treat this? You want to make sure you give oxygen. Of course, all your treatment is directed by your physician. So when somebody's distressed, they're hypoxic, you want to try putting on some oxygen, getting the attention of your ICU attending physician for guidance. You want to, you know, if this person has like lines already placed, like a central line, maybe they have a swan in, you want to make sure that you get your, you continue monitoring the CVP, the PA pressures, and then you want to give like the diuretics, or they may order beta blockers as well, calcium channel blockers too. Sometimes they may be able to give, depending on the kind of heart function, they may be able to give fluid. FiO2, you want to keep above, oh, well, the PaO2 you need to keep above 80%. This person may need to be intubated. They may need blood administered to help this cardiogenic shock. They may have inotropes, like the butamine, norepinephrine, and dopamine sometimes. They may require an IABP when the shock is not, you know, quickly reversed with medications. And of course, there are contraindications to that. You want to improve the contractility. So you want to treat any kind of hypothermia, any acidosis, hypokalemia, or hypomagnesemia. So all those need to be treated to improve contractility if they're low. Cardiac output, you want to make sure you're monitoring that according to your physician orders. And you want to manage your arrhythmias. So you're going to watch your EKG, you look out for tachycardia, any kind of arrhythmias. And also you want to monitor any pain or agitation and treat as ordered. And anxiety, anything to reduce increased work of breathing is always a good thing, so your oxygen demand may not be so high. Sometimes we use, especially in MIs that, you know, are like witnessed, they use fibrinolytics, you know, and they may use nitrates. In our surgical CVICU population, nitrates are usually not the first choice of treatment. And usually in the surgical population, their blood pressures tend to be on the lower side in cardiogenic shock. So it's most likely that you will treat hypotension with your vasopressors or inotropes. And then you want to revascularize with either PCI or cabbage for STEMI patients. And cardiogenic shock patients who present 0 to 6 hours after symptom onset before undergoing a PCI have the lowest mortality rates. 80% are asymptomatic 18 months later. And I told you about the risk factors for the poor outcome. That's over age 75, a previous MI, shock within the last 24 hours, or multiple vessel disease. So that's your quick review of cardiogenic shock. I hope it was enriching.